Juvenile rheumatoid arthritis, JRA, officially known as juvenile idiopathic arthritis, JIA, represents the most prevalent form of arthritis in children under 16, affecting approximately 1 in 1,000 children worldwide. It's a chronic condition that not only affects the joints, but can also have systemic impacts, meaning it can affect the entire body including organs. JRA is an autoimmune disorder, which means the immune system, which normally helps protect the body from infection and disease, mistakenly attacks healthy cells and tissues. In the case of JRA, the targets are primarily the joints, but other parts of the body can be affected as well. This autoimmune response causes inflammation, resulting in swelling, pain, and if uncontrolled, can lead to joint damage. JRA is classified into 3 main types based on the number of joints involved and the symptoms exhibited within the first 6 months of the disease. Oligoarticular JRA, also called post-articular JRA, this is the mildest form and affects 4 or fewer joints. The large joints, such as knees and ankles, are typically involved. Children with oligoarticular JRA are at risk of developing eye inflammation, specifically uveitis, which can be serious if not treated promptly. Polyarticular JRA, polyarthritis, this form affects 5 or more joints and can be more severe. It often affects the small joints of the hands and feet, although larger joints and even the jaw can be involved. Polyarticular JRA can be rheumatoid factor positive or negative, with rheumatoid factor positive being more similar to adult rheumatoid arthritis and potentially more severe. Systemic JRA, systemic onset JIA, this type affects the entire body. Symptoms include high fevers that often spike in the evenings and then suddenly drop to normal, a rash, and liver, spleen, and lymph node enlargement. Joint pain may actually be less severe than in other types. The precise cause of JRA isn't fully understood, but it's believed to involve a combination of genetic and environmental factors. Children with specific genetic markers are at an increased risk. Environmental factors, such as viruses, may trigger the disease in a genetically susceptible child. Diagnosing JRA can be challenging because there is no single test for the disease. Doctors rely on a combination of medical history, clinical examination, blood tests to look for inflammation and autoimmune markers, and imaging studies, like X-rays or MRIs, to diagnose the condition and rule out other potential causes of the symptoms. Treatment aims to control pain and inflammation, prevent joint damage, and maximize joint function. Treatment plans often include medications, including NSAIDs like ibuprofen, corticosteroids to control severe inflammation, and disease-modifying anti-rheumatic drugs, DMARDs, such as methotrexate. Biologic agents, which are newer drugs that specifically target the immune system responses, are increasingly used for children who do not respond to other treatments. Physical therapy, to keep joints flexible and muscles strong. Occupational therapy, to help manage everyday activities without stressing joints. Living with JRA can be challenging, but with the right management, most children can lead a full and active life. Key strategies include education. Understanding the disease can help children and families manage the condition more effectively. Regular medical care. Ongoing care from a pediatric rheumatologist is vital. Supportive therapies, including nutrition, exercise, and possibly counseling. Support groups and counseling can also play an important role in helping not just the affected child, but also the entire family cope with the challenges of the disease. By taking a proactive approach to treatment and making use of the resources available, families can help their children achieve the best possible outcomes.